In this lecture, we will discuss AV reentrant tachycardia, including its mechanism, common causes, along with two main types, orthodromic and antidromic AVRT, and their respective EKG features. AV reentrant tachycardia, or AVRT, is a form of paroxysmal supraventricular tachycardia that can occur when a reentrant circuit is present outside the AV node through an abnormal conduction pathway that connects the atria to the ventricles. You may also hear this abnormal AV connection referred to as an accessory or pre-excitation pathway or bypass tract. And if you look here, okay, you can see that tract right here in green, all right? That's our AV bypass tract, and it's going from the atria to the ventricles, all right, hence atrioventricular accessory pathway. Now, what we mean when we say pre-excitation is that there's early ventricular activation due to impulses bypassing the AV node through this accessory pathway. This can occur in one of the two types of AVRT that we will discuss shortly. So what we're saying is sometimes you can have this conduction pathway that comes from the atria, bypasses our AV node. Remember, at our AV node, we have a normal physiologic delay, and so we can have an impulse that comes down this tract and starts depolarizing the ventricles earlier. Okay, so that's what we mean by that. And one of the forms we'll look at has that type. All right, so the majority of these accessory AV connections are congenital and present at birth. They can appear in multiple different anatomical locations, and there can be even more than one accessory pathway present in some individuals. One example is Wolff-Parkinson-White, or WPW syndrome, which is characterized by congenitally abnormal accessory pathway, episodes of AVRT, and a risk of sudden cardiac death. The accessory pathway in WPW syndrome is typically referred to as the bundle of Kent, or AV bypass tract. Another means by which these AV connections can come about is through surgical intervention. For instance, it's possible to have an AV connection to be created surgically from the right atrial appendage to the right ventricular outflow tract. Okay, so how does this mechanism work? Well, if you can imagine, we have an accessory pathway that can conduct impulses antegradely, retrogradely, or even in both directions. The majority of these accessory pathways allow conduction in both directions, okay, so both antegradely and retrogradely, followed by those that only allow it in retrograde conduction, okay? And the least common of these are those that only allow antegrade conduction. And we will learn that the direction of the conduction affects what we see on the EKG. Let's now take a look at how this reentry comes about. So if an action potential is able to move down the accessory pathway and then return retrogradely through the AV node, or if an impulse is able to move down the AV node and then return retrogradely through the accessory pathway, you can start to see how we can create a reentry circuit. If a reentry circuit results in a tachyarrhythmia involving the accessory AV connection and the AV node, this is what we refer to as an AV reentrant tachycardia, or AVRT, as we see here. Okay, so let's just review that. So what we're saying here is that for some reason, if you have this accessory pathway, which is this here, so our accessory pathway in our AV node, sometimes you can have a circuit that either comes down our accessory pathway first and then returns up, okay, and then you have this circuit that continues, or you can have it going in the opposite direction, in which it comes down our AV node first and then returns retrogradely up to the atria, okay, and that circuit will occur. All right, so AVRT is often triggered by a premature atrial or ventricular contraction. In other words, there is some initiating factor like a premature beat that throws off the timing of the rhythm and results in an abrupt onset of this arrhythmia, similar to what we see in AV nodal reentrant tachycardia. Now, AVRT can be subdivided based on the direction of the reentry conduction into orthodromic or antidromic. In orthodromic AVRT, which is more common and actually the most common form of narrow complex tachycardia in children, antegrade conduction occurs through the AV node, while retrograde conduction occurs through the accessory pathway. This is what can occur in individuals with concealed pathway. Now, concealed pathway simply means that there is an accessory pathway present, but that accessory pathway only conducts retrogradely. Therefore, all antegrade conduction will occur through the AV node without any ventricular pre-excitation or its corresponding features present. So let's first look at this orthodromic type, okay? And what we're going to see is that this is a narrow complex tachycardia that we have going on here, okay? So what we have is antegrade conduction, meaning we're going from forward from the atria to the ventricles, going in this direction, all right? And then we're going to have retrograde conduction going from the ventricles to the atria through our accessory pathway. Here's our accessory pathway, and notice that we're going in that direction. So this is the orthodromic type, all right? And in this case, there's no pre-excitation, right? So why is that? Because we are coming first down our AV node, okay? We're not in Wolff-Parkinson-White, and what we'll see in antidromic is that we have a conduction that first comes down our accessory pathway. So if you imagine, here's our accessory pathway. First, it comes down, and because of that, we have this depolarization of the ventricle, or ventricular pre-excitation, and we'll get that delta wave in the wide complexes. In this case, in orthodromic, instead of going down our accessory pathway first, we go through our normal antegrade conduction down our AV node, and then as it comes down through the ventricles, it returns back through the accessory pathway to the atria. Okay, so hopefully that makes sense. Now in the second form, the antidromic AVRT, this is antegrade conduction over the accessory pathway and retrograde conduction through the AV node. Okay, so the opposite way. In this case, we do have ventricular pre-excitation from the accessory pathway, and therefore we will see those corresponding features. Okay, so this is like what we see in WPW syndrome, all right, with the delta wave. So this is antidromic, and this is a wide complex tachycardia. All right, so what you have going on here is we have, again, antegrade conduction down our accessory pathway. So now in this case, we're going from the atria to the ventricles, antegradely through our accessory pathway. Okay, and because of that, we're going to start to depolarize our ventricles. All right, with that, we're going to have slow cell-to-cell depolarization. So on the EKG, we see these wide complexes. Okay. Remember, if you saw here in the orthodromic, we didn't have that, so we have narrow complex QRS complexes there. Okay, so again, antegrade down our accessory pathway, and then retrogradely going back through our AV node. Okay, and you could see that cycling around. So this is the antidromic type. Okay, antegrade accessory pathway and retrograde AV nodal pathway. Okay, and here we do have pre-excitation. So let's briefly go through our chart to make sure we didn't miss anything here. So again, AVRT, or AV reentrant tachycardia, has an accessory pathway that allows for this reentrant circuit to form, okay, and it's between the accessory pathway and the AV node. And if this then develops from a PAC, a premature atrial contraction or ventricular contraction, and it goes into this tachycardia, that's what we call AVRT, the tachycardia. Okay, now causes, we said congenital, such as WPW, is more common than some of those surgically created pathways. In terms of the AP conduction, accessory pathway conduction, both directions is the most common, followed by the retrograde. And remember, the retrograde is where we have that concealed pathway that can form, okay? And then we can have this antegrade as the least common way that we can have these accessory pathways conduct. Okay, so remember, AVRT is a form of paroxysmal supraventricular tachycardia. Okay, has an abrupt onset and it has an abrupt termination. Okay, now we mentioned the two types that are based on the direction of the reentry mechanism. We had the orthodromic, and then we had the antidromic. Remember, orthodromic results in these narrow QRS complexes, and it has antegrade conduction down the AV node and retrograde conduction through our accessory pathway. Okay, so remember that retrograde conduction through the accessory pathway is what we see in the concealed pathway. So the circuit is from the atria to the AV node to the ventricles to the accessory pathway, and then it goes to the atria and then continues this cycle. Now with the antidromic AVRT, we have a wide complex. Okay, so we go from narrow to wide. Why is it wide? Well, in this case, we have antegrade conduction through our accessory pathway, just like we see in WPW syndrome, right, with the delta wave. And in this case, we have retrograde conduction back through our AV node. So the circuit is from the atria through our accessory pathway to the ventricles to the AV node, and then again back to the atria and so forth, and then it continues. Now, in terms of the regularity of these are typically regular rhythms. Okay, so the intervals between each one of these complexes tends to be the same. The rate is often between 200 and 300 beats per minute. So if we look at the rate here from one R wave here to the next, it's a little over about between 1 and 2 of the thick boxes. So 300 over 1 is 300 beats per minute, and 300 over 2 is 150. So it's somewhere between that, closer to the 200 range. Okay, and the same thing here if we were to look at our rate in the antidromic form. Now in terms of the P waves, in this case we're going to have retrograde and inverted P waves. So why is that? Okay, so notice in both cases, okay, if we look at this orthodromic case where we're coming down antegradely, okay, through our AV node, and then we're going to come back retrogradely, and that's where we start depolarizing our atria, okay? And because of that, we're going in the opposite direction from our sinus node. Imagine we're coming now back up this way instead of our sinus node that fires this way. So because we're going to have this conduction going in the opposite direction, we will have these retrograde P waves because they are occurring after the QRS. So imagine we depolarize the ventricles and then we come back up and depolarize the atria. Okay, and because we're going in the opposite direction, that's where we get the inverted P waves. Okay, and if you look down here, you can actually see them. So notice our P waves present here. Okay, they're right there, they're inverted after our QRS complexes, okay, so retrograde and inverted. They tend to be harder to make out in the antidromic form, but again, you have that similar thing where you're coming down the ventricles, depolarizing them, and then you're coming back up and depolarizing the atria. Okay, so again, retrograde and inverted P waves you'll see. Now, the P waves, if you can see them in the antidromic form, will have a 1-to-1 ratio, and that's the same thing with the orthodromic AVRT. Okay, now in this case, we'll look at the RP interval. Okay, in the RP interval, what I mean by this is we're looking from the R wave, so from this R wave to our P wave. So that interval there, if you were to take that point right there, that would be our interval. And in this case, in the orthodromic form, we have a short RP interval. So why do we have a short RP interval in this orthodromic form? Okay, well, think about it. Okay, so what we have in orthodromic is we come down our normal AV node, okay, and then we come back this way, okay? Whereas in the antidromic, let's just erase this so you can see, the antidromic, we're going in the opposite direction, okay? We're coming down our accessory pathway, then going up. As we go up, we go through our AV node, okay? And that can slow things down, whereas if we come this way and go back up our accessory pathway, we're already starting to depolarize our atria. So what we'll see is a short RP interval in this orthodromic form. Okay. In terms of the QRS interval, remember orthodromic AVRT, we don't have that ventricular pre-excitation, so we have normal QRS intervals between 70 and 110 milliseconds. And with the antidromic form, because we're coming down through our accessory pathway, we start to depolarize our ventricles early, okay, just like in WPW syndrome, and we can see those delta waves appearing early, okay, that initial slurring of the QRS complex. There's typically no dropped beats and no grouping in either of these. Well, that's the end of this lecture. We discussed AV reentrant tachycardia, including its mechanism, common causes, along with two main types, orthodromic and antidromic AVRT, and their respective EKG features. I hope you learned something.